This is the title of today's lecture. What is positive pulmonary neuroendocrine carcinoma? Molecular subtyping classification of small cell lung carcinoma has recently been reported by Rudin and is currently attracting attention. If you are not familiar with the molecular subtyping classification of small cell carcinoma, please check PubMed before listening to this lecture. You should be able to find many related papers. Here I list the main histological subtypes of the lung tumor. Today I will talk about neuroendocrine carcinoma, including small cell lung carcinoma, SCLC, and large cell neuroendocrine carcinoma, LCNEC. First, I will talk about small cell lung carcinoma, SCLC. Small cell lung carcinoma, SCLC, is correlated with smoking. So almost all patients with small cell lung cancer carcinoma are heavy smokers. SCLC is highly aggressive and prone to metastasis. When SCLC is detected through a lung biopsy, the tumor may already have metastasized to other organs and be at an advanced stage. In most cases, surgical resection is not feasible except in stage 1. However, SCLC is highly sensitive to chemotherapy and radiation therapy compared to non-small cell lung cancer. Non-small cell cancer is squamous cell carcinoma, adenocarcinoma, and large cell carcinoma. However, this sensitivity to chemotherapy and radiation is only temporary. The cancer initially decreases significantly, but quickly develops resistance to chemotherapy and radiation therapy, leading to tumor growth. The overall 5-year survival rate for small cell cancer is only 10%. Unfortunately, treatment strategies and prognosis for small cell lung cancer have remained largely unchanged for the past 30 years. This is a cut surface of SCLC. Grossly, SCLC is a large perihilar mass with subsequent peribronchial compression and obstruction. The tumors sometimes spread along bronchi in a subepithelial and radial pattern. SCLC is a malignant epithelial tumor that consists of small cells with scant cytoplasms, poorly defined cell borders, finely dispersed granular nuclear chromatin, and absent or inconspicuous nucleoli. This morphology is similar to malignant lymphoma. And also, SCLC express neuroendocrine markers such as CD56, chromogranin A, and synaptic fission. And recently, INSM1 is also possibly good best neuroendocrine marker. And also there is a combined small cell carcinoma, so that is composed with not only small cell carcinoma component but also non-small cell carcinoma component. In small cell lung carcinoma, treatment strategies and prognosis remained unchanged for 30 years because no promising molecular targets for treatment were identified. But in 2019, Rudin reported that SCLC can be subtyped into 4 groups by 4 molecules: ASCL1, NeuroD1, POX-F3, and YAP1, based on genomic data of primary SCLC samples and cell lines. The fact that the 4 molecules are mutually exclusive means that each molecule is important for each subtype. Each molecule is described very briefly. ASCL1 and NeuroD1 are transcription factors implicated in the neuroendocrine differentiation. POX-F3 is an important master regulator for chemosensory cells. YAP1 is the effector of Hippo pathway. YAP1 attracted attention as an important marker for non-neuroendocrine type SCLC. However, several subsequent studies, including this Baines report, also suggested that YAP1 expression alone cannot define a single group in primary SCLC. At present, YAP1 positive SCLC remains unclear. What is YAP1 positive SCLC? I explained the meaning of YAP1 expression in neuroendocrine carcinoma from a pathological point of view based on the recent literature and our own studies. In the ruling figures, you can see here green, red, and blue boxes. Red and green boxes are primary tumors, and blue boxes are cell lines. SCLC-Y group is mostly composed blue box, so SCLC cell lines. But the other type, SCLC and SCLN and SCLCP are composed of primary SCLC and SCLC cell lines. So SCLC-Y, YAP1 positive SCLC, is a concept mainly established from SCLC cell lines. These are 51 cell lines expressions of YAP1, POX3, NeuroD1, ASCL1, and INSMA. INSMA is a very popular neuroendocrine marker. And among 51 SCLC cell lines, in the cancer cell encyclopedia, at least 18%, 9 of 51 cell lines show the high expression of YAP1 gene. So SCLC-Y is present in cell lines, but not in primary tumors. Therefore, we need to consider how the SCLC-Y cell lines were established. So let me explain our study where we reported that loss of YAP1 characterizes neuroendocrine differentiation as imparable and resistant to chemotherapy. We collected 15 SCLC cell lines and performed cluster analysis using the gene of Hippo pathway molecules and neuroendocrine markers. Any markers were written in red color, and Hippo pathway molecules were written in black color. 15 cell lines are classified into 2 groups: YAP1 positive and neuroendocrine marker negative group, and YAP1 negative and neuroendocrine marker positive groups. Those groups. Interestingly, YAP1 negative cell lines, these cell lines, YAP1 negative cell lines are floating type cell lines, while YAP1 positive cell lines are adherent type. Anyway, YAP1 is inversely correlated with neuroendocrine marker, right? Next, we focused on NSCLC cell lines. Among 40 non-small cell lung cancer cell lines, VMRC-LCD uniquely showed highest expressions of neuroendocrine marker. This is VMRC-LCD. Showed high expression of neuroendocrine markers such as ASCL1, synaptophysin, chromogranin A. Red arrows indicate VMRCLCD, and interestingly, we also found that loss of YAP1 was characteristically seen only in VMRCLCD among 40 cell lines. We speculate VMRCLCD is not adenocarcinoma, but LCNX cell line. We perform limited histochemical analysis of YAP1 using lung cancer tissue microarray, 201 cases including, and found that 97%, 183 of 189 SCLC case, NSCLC cases except LCNEC cases were YAP1 positive. We performed immunohistochemical analysis for YAP1 using 40 SCLC cases and 30 LCNEC cases. 98%, 40 of 41 of small cell carcinoma are YAP1 negative. So most of the SCLC were YAP1 negative. One YAP1 positive case was later found to be a squamous cell carcinoma. In LCNEC cases, 60%, 18 of 30 cases were YAP1 negative. So LCNEC will be discussed later. In our analysis, loss of YAP1 characterizes neuroendocrine differentiation in lung cancer cell lines. 98% of primary SCLC are YAP1 negative. In contrast, 60% of LCNECs are YAP1 negative. And 97% of primary and non-small cell lung cancer, except LCNEC, are YAP1 positive. Could YAP1 positive SCLC cell lines have been established from an SCLC misdiagnosed as SCLC? Here we show the expression of the 4 molecules and INSM1, the neuroendocrine marker. INSM1 is in 11 floating type SCLC cell lines, 3 adherent cell lines, and 3 non-small cell lung cancer cell lines. INSM1 is considered a promising marker as a neuroendocrine differentiation with high specificity. In this view, the 3 adherent type SCLC cell lines express YAP1 and the negative for other markers. This expression pattern is similar to non-small cell lung cancer and SCLC cell lines. So at the time, I had concluded that YAP1 positive SCLC cell lines were established from non-small cell lung cancer, misdiagnosed as SCLC small cell lung cancer, and floating type SCLC cell lines were true SCLC. However, after reading Parsal's report in 2020, I realized that my conclusion was wrong. Parsal et al. Performed immunohistochemical analysis using 39 SCLC CTC derived CDX. Although there was no predominantly YAP1 positive case among 39 CTC derived SCLC tumors, more than 0.2% cancer cells were positive for YAP1 in 10 of 39, and more than 1% were positive for YAP1 in 2 of them. Right? These figures by Parsal show that many of the CTC-derived tumors contain a small number of YAP1 positive and neuroendocrine marker negative cells as minor components. So this part shows the YAP1 positive, and rest, which is anti-neuroendocrine marker, and it shows a negative for synaptophin, which is neuroendocrine marker. So these figures shows the CTC-derived tumors contain a small number of YAP1 positive and neuroendocrine marker negative cells as minor component, Morphologically, SCLC appears to be a relatively homogeneous tumor, but it is a heterogeneous tumor. Reviewing past literature, and I noticed that in 2011, Calvo et al. Established two types of cell lines from the same SCLC, small cell lung cancer tumors, from mice, an adherent line with EMT phenotype, and the floating cell line with the neuroendocrine phenotype. Of course, I don't really know since no Japan staining was done, but I speculate adhesive type is Japan positive and floating type is Japan negative. Going back even further, in 1985, Kane and Gazzar reported that there are two types of SCLC cell lines. Classic type, which is floating with the neuroendocrine phenotype, and variant type, which is adherent with non-neuroendocrine phenotype. Of course, I don't really know since no Japan staining was done, but I speculate that classic type is Japan negative and variant type is Japan positive. Of note, variant types SCLC cell lines frequently originated from post-therapy tumors that recurred and were more resistant to radiation than the classic type. This result suggests that Japan-negative SCLC is sensitive to chemotherapy and radiation, but Japan-positive SCLC is resistant to chemotherapy and radiation. In 1996, Dr. Fushimi of Osaka Prefectural General Hospital reported that in SCLC cases, more large cells are observed in the primary lesion of post-treatment autopsy cases compared to pre-chemotherapy cytology and biopsy tissue. They call this histology as mixed small cell and large cell carcinoma. We speculate that these large cells are Japan-positive cells. However, we pathologists often experience non-NA type, non-neuroendocrine type cancers turning into neuroendocrine type, but I wonder if it is possible for neuroendocrine type to transform into non-neuroendocrine type. Recent study by Ireland revealed that MYC activates Notch signaling and transiently reprograms ASCL1 positive cells into Japan positive cells. So, neuroendocrine type cells can be transiently reprogrammed into non-neuroendocrine type cell. So, morphologically, SCLC appears to be a relatively homogeneous tumor, but in reality, it is a heterogeneous tumor with a mixture of neuroendocrine and non-neuroendocrine type. Again, I reviewed the Japan staining of SCLC cases, small cell lung cancer cases. Small cell lung cancer cell is mostly negative for Japan, but upon close examinations, a few of Japan positive cells are seen. Please look at here, this part. Japan positive cells are clearly larger than surrounding Japan negative tumor cells. This is pre-treatment SCLC cases, small cell lung cancer cases, but as can be seen, even before treatment, small amounts of Japan positive cells can be found in the mixture. I showed two possibilities for the establishment of SCLCY, Japan positive cell lines. SCLC is essentially Japan negative and exhibits neuroendocrine differentiation, but a few cells in the tumor mass are transiently reprogrammed into Japan positive and non-neuroendocrine type cells. The reprogramming may be promoted through the process of the acquisition of resistance to chemotherapy and radiation therapy. SCLCY line may be irreversibly established from these minor components, SCLC, in SCLC. The other possibility is that SCLC-Y cell line may have been established from non-small cell lung cancer cases mimicking small cell lung cancer. It is well known that some non-small cell lung cell line NSCLC, for example, basaloid squamous cell carcinoma, histologically mimic SCLC. Gay and colleagues proposed SCLC inflamed as an alternative to SCLC-Y. SCLC inflamed express high levels of immune-related molecules and is sensitive to immune checkpoint inhibitors. However, SCLC inflamed expresses high levels of rest and has an EMT phenotype, and also resistance to chemotherapy induces subtype switching to SCLC inflamed. But I think these features overlap in SCLC-Y. At the AACR, it was also reported that based on cluster analysis, the SCLC-Y and SCLC-I groups were most sensitive to the immune checkpoint inhibitor durvalumab. This result suggests that SCLC-Y overlaps SCLC inflamed and is likely to respond to immunotherapy. Finally, I explained the Japan-positive LCNEC, large cell neuroendocrine carcinoma. In 1991, Dr. Travis proposed LCNEC, non-small cell carcinoma with neuroendocrine differentiation. In new WHO classification, LCNEC and SCLC were categorized as high-grade neuroendocrine tumor or neuroendocrine carcinoma. However, without immunostaining for neuroendocrine markers such as NCAM1, synaptophysin, or chromogranin A, so LCNEC could be possibly classified as adenocarcinoma by pathologists. And also about 3 to 4% of lung adenocarcinomas show neuroendocrine marker expression even without neuroendocrine morphology. Dr. Rechtman divided pure LCNEC cases into two groups: SCLC type with TP53 and RVR mutations, and non-small cell lung cancer cell types with STK11, KRAS, KEAP1, NF2L2 mutations, because the P53 mutation and RVR mutations are inevitable in SCLC. And also KRAS or STK11 mutations are very frequent in non-small cell lung cancer. Later, Dr. George classified LCNEC into two groups based on gene mutations and expression of transcription factors. Type 1 is considered to be equivalent to an SCLC type and type 2 to SCLC type. According to George, type 2 LCNEC express high levels of YAP1, immune-related molecules and Notch molecules. So I speculate that type 2 LCNECs may be the counterparts of SCLC-Y or SCLC inflamed. So we review the Japan staining pattern of 30 LCNEC cases. Of the 30 cases, 18 cases were mostly YAP1 negative, like left side, and ASK1 was diffusely positive, like right side. The pattern is almost identical to that of small cell carcinoma. But 12 cases, 40%, were YAP1 positive, and the YAP1 positive LCNEC exhibit that conspicuous mixture of YAP1 positive and YAP1 negative cells. YAP1 positive cells components are negative for ASK1, like this here, and YAP1 negative cell components are positive for ASCL1. A few YAP1 positive LC-NECs showed a diffuse YAP1 positive pattern in which YAP1 positive cells were neuroendocrine marker negative or weakly positive. We also performed survivor analysis of high-grade neuroendocrine tumors, depending on YAP1 positivity and with or without chemotherapy. And YAP1 negative case with chemotherapy showed better prognosis than YAP1 negative cases without chemotherapy, and also YAP1 positive cases with chemotherapy. Okay, without going into detail, these results suggested that YAP1 negative high-grade neuroendocrine tumors, YAP1 negative neuroendocrine carcinomas were chemosensitive, and the YAP1 positive neuroendocrine carcinomas were chemo-resistant. So recently, the Ku et al. Reported that YAP1 drives further conversion and chemo-resistance of small cell lung cancer, like this. Focusing only on SCLC, it is difficult to understand the true role of YAP1 or other markers. However, by expanding the field of view to NSCLC, the significance of these molecules may become clearer. We present the cluster analysis of 188 lung cancer cell lines, including 137 NSCLC cell lines and 51 SCLC cell lines based on the gene expression of neuroendocrine markers, including chromogranin A, synaptophysin, NCAM1, INSIM1, TTF1, and POX3, and hypopathway effectors, including YAP1 and WWTR1. Cells are divided into two groups, NA type right side and non-NA type left side. And all of the non-NA type cells exhibit high expressions of YAP1, and all of the NA type cells exhibit low expressions of YAP1. On the other hand, high expression of POX3 was observed in both NA and non-NA type. The high expression of POU2F3 is not specific to neuroendocrine tumors like TTF1. We can therefore conclude that the loss of YAP1 is essence of any differentiation of cancer cell lines, regardless of whether they originated from primary SCLC or NSCLC. Conclusion. SCLC1I is a concept mainly established from SCLC cell lines. SCLC is a heterogeneous tumor in which most cells exhibit neuroendocrine features and lack YAP1 expression. However, a small number of cells that have lost the characteristics of neuroendocrine features exhibit YAP1 expression. SCLC-Y is thought to have been established from the YAP1 positive cells, and it should not be applied to the classification of primary SCLC. Conclusion 2. Many, but less than half of the LC-NECs exhibited a mixture of YAP1 positive and neuroendocrine marker negative cells, and YAP1 expression correlated with chemo resistance. At present, where there is no gold standard chemotherapy for advanced LC-NEC, immunostaining for YAP1 may help predict susceptibility to chemotherapy. Further analysis of the correlation between YAP1 expression in LC-NEC and the genetic background and sensitivity to therapies, including immunotherapy, is required. Our lab is mainly involved in lung cancer research. We conduct research on lung cancer based on pathological morphology. This time I talked about small cell lung carcinoma and LC-NEC, but we also deal with lung adenocarcinoma, sarcomatoid carcinoma, and various other types of cancers. Thank you.